At last, we have a deal.
The U.S. Senate agrees to the largest stimulus package in the country's history to fight the coronavirus pandemic as healthcare workers face a shortage of equipment. Hello, I'm Anand Naidu, and this is The Heat. The number of people with coronavirus is growing. More than 450,000 people have been infected worldwide and more than 20,000 have died. To try to stop the spread of the virus, countries are taking tough measures. In India, where Prime Minister Narendra Modi ordered a lockdown of 1.3 billion people, police are punishing those who disobey. In Spain, the number of deaths surpassed 3,400, making it the country with the second highest death toll behind Italy. Spain has confirmed more than 47,000 cases, and the government expects this number to climb in the next few days. In the United Kingdom, Prince Charles, the next in line for the throne, tested positive for coronavirus. He is self-isolated and in good health and good spirits, according to a spokesman for Buckingham Palace. In Brazil, President Jair Bolsonaro is under fire after making an address to the nation minimizing the pandemic and urging Brazilians to get back to work. And here in the United States, the Senate agreed to a $2 trillion stimulus package. The money will help fight the coronavirus and also support businesses suffering from the economic slowdown. To talk about the economic impact of the pandemic, let's bring in our first two panelists from Los Angeles via Skype. Lisa Kennedy is the managing principal and chief economist for Epiphany, and also via Skype here in Washington, D.C., John Sitilides is a geopolitical strategist for Trilogy Advisors. Thanks to both of you for joining us. Lisa, let me start with you. President Trump wants to, as he puts it, reopen the economy. He's talking about a date of April 12th that coincides with the Easter holiday. But at the same time, we're also seeing a terrifying rise in the number of infections. In fact, in New York alone, the number is doubling every 3 days. So the question is this practical? Is it doable? Can the economy reopen on April 12th?
So that's a really good question. And I think that there's such a focus right now on when the economy can open. So will it be open? And as of Easter, I think that's there's a lot of debate about that right now. I think it's unlikely. I think also that we should really focus on the solution that's going to get us out of this. It's going to help us open the economy rather than thinking about particular dates and deadlines. There's a lot of things that we can potentially do to help alleviate some of the economic pressures that folks are feeling. But I'd say that's probably the focus right now, and obviously making sure that the public feel safe.
John, the president says he wants to put the economy back on track because, as he put it, the cure should not be worse than the problem. In fact, he did send out a tweet in which he said, our people want to return to work, they will practice social distancing and all else, and seniors will be watched over protectively and lovingly. We can do two things together. The cure cannot be worse by far than the problem. Congress must act now. We will come back strong. Well, of course, Congress has acted, as we know. We'll get to that in a moment. But, John, the risk here is that if people go back to work and then we get a huge increase in the number of infections, then it's going to take even longer to get the economy back on track. So how big a risk is this?
I think we need to be careful, Anand, as to what exactly the president is talking about here. I don't think we're looking at a quote-unquote L-shaped return where everything has plunged the last couple of weeks and everything simply shoots back in a few weeks, whether it's Easter time or anything along those lines. I think we're looking at more of a, what I would call a U-shaped recovery, but citizens, business executives, small business owners, investors, they all need some type of certainty that we are not just going to leave this period indefinitely ahead of us, that we have to have some type of deadlines to focus the mind, to focus our energies. Now, those deadlines can always be adjusted, but people want some measure of certainty in their lives. It's just human nature. And I don't think you have an American culture, a citizenry that's going to simply sit back and have government officials tell them, stay at home, we don't know how long this will be. It could be 6 months, it could be a year, it could be 18 months. That's not sustainable. So president's got a tough task. He's got to make sure that when the medical and health experts are giving him the best advice as to how to flatten the curve, slow the spread, and make sure that we don't overwhelm our health system, that he's also providing the kind of objectives that everyday people, workers, business people can also work with to try to see how we start to move to some measure of normalcy.
Lisa, looking at the broader impact on the economy, the chairman of the St. Louis Federal Reserve predicted a few days ago that unemployment, that rate could go up by as much as 30% and GDP could actually halve. It will be down by 50%. What do you make of those predictions?
We don't know right now so exactly the effect on GDP. I think that a lot of predictions are coming in about 0.4% for the year. It could be a little better. It could be a little worse. I think there's a lot of unknowns, but yeah, it's going to be really tough on the economy. We're certainly going to see recession as a possibility, a great possibility that grows every single day. But yeah, I think that if we can get out of this more quickly, we can avoid some of the extinction level events in businesses that, so basically giving businesses the CPR they need in order to stay open as long as they can. With the stimulus package, sending more money to those people who are out of jobs, I think that's going to be important. You know, you think about this, like 86% of people in the service sector, that's where most of the jobs are within the U.S. About 40% of GDP is really coming from those non-essential businesses that have been shut down. And I think a lot of economists estimate there are about 1.5 million new jobless claims that were filed last week. And so we are focused on this, obviously, in sort of measuring what the impact will be on GDP, but it could be significant. We just don't know yet. And I like what John said in terms of that V shape. We're probably not going to see a V shape, but we still don't know exactly what the impact on GDP will be, but it's going to be bad to relatively significant.
All right, Lisa, I love the way the alphabet's being used to describe the recovery. We have V-shaped, U-shaped. Could it be a W-shaped? Could we have a recovery and then another collapse?
Yeah, so there's a lot of discussion. If you look at the modeling the Imperial College group has done, this is some of the work that both convinced Prime Minister Johnson as well as President Trump to think about a shutdown. When you see that, there is the projection that you could see this come out again in November. So I think that there is significant concern that we're not going to get out of this quickly. And there are a number of things that we can do as healthcare infrastructure grows. We need to test. And not just testing who has the flu, but also who can go back to work, who has the antibodies. So there's a number of things that we could do in order to get people back to work.
John, there's clearly a political dimension to this as well, especially looking at those unemployment numbers and the predictions of where it could go. Even Steve Mnuchin, the Treasury Secretary, is talking about an unemployment rate of 20%, and we know that we're in the middle of an election campaign for a president. I mean, could there be a situation where we could lose jobs permanently?
Well, it depends on how prolonged this, recession, hopefully won't become a mini depression, will endure. But, you see tremendous damage already to the airline industry. We need to make sure that we don't have a complete collapse of domestic airlines, for instance. But I want to touch on a couple of the points, Anand, if you'll permit me, that Lisa mentioned that I think are also very important for us to understand and converge upon as we move forward as a nation and then with our partners around the world. We're going to have to learn to live with the coronavirus probably for several years to come at the very least. So I don't think this is a matter of eliminating the virus. When we do come out of this immediate recession, I'll call it for now, that we're in right now, whatever the numbers may be on GDP losses or unemployment numbers, the thing is to mobilize the United States and our industrial partners around the world, not only for tests and treatments, as Lisa correctly notes, but ICUs, ventilators, masks. We're going to be living in a different way for some time to come. And there could be another hit in the fall. There could be a hit next spring. But we're going to have to learn to live with this virus with that balance of living with it and returning to normalcy as much as possible. And it won't be equally spread throughout the United States. As you correctly note, New York has almost half of all of the infections in the United States, and it may remain an epicenter for the foreseeable future. But large parts of the United States simply don't have to deal with the kind of crisis proportions that New York City or San Francisco or Washington State or perhaps New Orleans may be dealing with in the weeks ahead. So how do we localize the response? Let governors make good decisions about how to localize and regionalize the responses and the quote unquote, return to normalcy in those areas where it's doable while we're protecting the most vulnerable in the epicenters. I think that's going to be an important strategy, whether it's for President Trump as he's seeking re-election, Joe Biden and looking to unseat President Trump, and frankly, for leaders in democratic countries around the world.
Lisa, let's look at one of the measures taken by the United States Congress. It's just passed a $2 trillion stimulus bill, the biggest in U.S. history. What's that going to do in the short term?
I think it could be very significant. When I looked at this this morning to see exactly what had been passed, there is a significant amount of money going towards infrastructure, towards healthcare infrastructure. So all the things that people on the front lines that are supporting and fighting this illness and caring for patients, we can see money going towards personal protective equipment. We can see it going towards ventilators that are necessary, more testing. So I think that's important. I think also what was edifying to see was not just loans to larger corporations, but also loans that will go to smaller businesses. Because, you know, if you think about smaller businesses really do power our economy much more than a lot of folks really recognize. Those who keep folks hired, so commit to that and are able to keep those folks hired throughout this period, then those loans, from looking at the legislation, will be forgiven. So what that means is it's not exactly a loan. It means that if you play by the rules or do what we hope to incentivize with this stimulus, or let's call it a survival package, by keeping people employed, because that's what we're trying to do. We're trying to allow these businesses to stay intact. From speaking to a lot of small business owners, they're looking for that. They're looking for something that's going to help them hold on. And also, I think the other thing is the checks that are going out to Americans. Many have lost their jobs. I think that's going to be key. They're probably going to need more than what's in the current stimulus package.
Yeah, John, what are your thoughts on that? You know, as Lisa points out, this is a big bill. There's help for big business, there's help for small business, there's help for families, help for individuals. But there are questions being asked on whether this is going to be enough. Will this have to be done again in a few months?
Well, we really don't know, do we? I mean, this is part of the uncertainty problem that we're all dealing with, whether we're citizens, whether we're working for other people, whether we're entrepreneurs and we've employed a number of people. We just don't know, Anand, but I think it's a move in the right direction, and I think that's going to be very important going forward, that we're directionally doing the right things. And so there's a part stimulus component to this package. I think what's very important is to allow as many people as possible to feel like their place in society and their place in the economy is intact and on hold until we get past this worst part of the pandemic response. I don't know that there's going to be much to spend on because, again, so many restaurants and bars and gathering places are closed. There isn't going to be that great a desire to spend money. It's a matter of not going under because you can't pay your rent, you can't pay for utilities, the things that don't go away month to month. So I don't know how much of a demand or response there's going to be, but I think what's going to be very reassuring for millions of Americans is that their place at their workplace, their place in society is going to be supported by the government, by this massive relief package. And hopefully, again, if we start to move towards some level of normalcy in those places where it medically makes sense throughout the United States, people don't want handouts. People want jobs. They want to earn their success and earn their way in society and in the economy. So if we provide that blanket, that assurance for people, I think that'll help get us through some of the worst social problems that might otherwise materialize in this type of an economic plunge. Keep everyone as intact as possible, and then start to forge forward as a nation towards a robust recovery, hopefully as early as the second half of 2020.
Lisa, John, we have to leave it there. Thanks so much for being with us.
Thanks for having us.
Thanks, Anand.
Okay, let's continue our discussion on the coronavirus pandemic. Let's bring in our next two guests. From Jackson Hole, Wyoming, Deborah Davis is an epidemiologist who's worked with the World Health Organization and the United Nations. And from New York, we're joined by Calvin Sun, an emergency room physician and a professor in emergency medicine. Thanks to both of you for joining us. Calvin, let me start with you. As we've just been discussing with the previous two guests, New York remains the state with the highest number of infections. What can you tell us about the state's ability or the state's healthcare infrastructure to cope with this?
The state's infrastructure, thank you for having me. The state's infrastructure was already at a capacity even before this pandemic came about. We were struggling with a lot of things that were inadequate, and in terms of preparation and personal protective equipment and a number of beds. I think 80% of our ICU beds were already full before this pandemic came along. So this has exacerbated the problem in a way that we were not prepared. And as of right now, we've already completely filled out our hospitals in terms of beds. We're almost at surge capacity in nearly every hospital in the city. And I've worked at 10 different emergency rooms in the last 18 days, 16 shifts in total, and every emergency room and hospital are going through the exact same thing. And some are actually already developing protocols for rationing ventilators, which is essentially determining who gets to live and who gets to die. And if things don't change in about 1 or 2 weeks, we might get to that point with multiple hospitals. There already are discussions on whether we even see these ventilators that are being promised to us. So essentially, we're stuck in this burning building trying to get as many patients out as possible before it collapses on us. And they're saying they're coming with fire trucks, but we don't see them.
Okay, Calvin, when you say if things don't change, what needs to change?
We need infrastructure. We need outside field tents in hospitals. We need to go full Wuhan and build a hospital from scratch that only can take COVID-19 patients in negative pressure rooms, filled with ventilators, and the ability to cohort them in a way that they cannot spread it to the general population and other patients who still present to the emergency room with life and limb threatening emergencies that are not COVID-19 related.
Deborah, what do you make of the response so far, especially in areas like New York and in the West, in the Northwest, in Washington State as well?
Well, I think that, as Dr. Sun has just said, they're all stretched to capacity. Remember, emergency rooms are where people go when they have a heart attack, when they have a stroke. And I want to thank the doctor for all the work that he's doing, covering so many different emergency rooms right now. It must be really, really challenging. I know from my colleagues in Seattle as well, they are stretched to the limit. So what they're looking for, that in Seattle, they've bought a hotel, rented it to convert it into a hospital. In New York, they're converting the Javits Convention Center into 4 hospitals. They're sending in a ship as well, but capacity is really stretched terribly thin. And if we must absolutely slow the growth of the disease, that's our only hope right now. It's why it's so important for New Yorkers and everywhere else for people to practice social distancing, because it's the only thing that has a chance of slowing the growth rate of this disease right now, since it's so highly contagious.
Those calls, Deborah, from professionals like yourself for people to practice social distancing, to wash their hands, to take other precautions, they've been in place now for some time. What kind of impact are they having?
Well, I think, ironically, the ones who are taking it most seriously are people like me who are older, but I've seen so many 20-somethings who think that they are immune. Unfortunately, as I indicated before, the reason why we thought they were less affected is because China, with its one-child policy, had such a small proportion of the population in that age group of 20 to 40. So as a proportion of the total number of deaths, it appeared to be much smaller. Now the CDC reported last week that 20% of the deaths are occurring in people under the age of 64. And contrary to the idea, they're not immune. So those that are partying on the beaches of Florida or carrying on at the base of ski mountains and thinking they're getting away with it are going to be sorely surprised. So I don't think that the young people are taking it as seriously as they should.
Calvin, the situation is so challenging right now. We're seeing people improvise. We're seeing them try to overcome these challenges. There are reports that health officials are considering experimenting with people sharing things like ventilators. Would that work? The
concern with sharing ventilators in terms of wide tubing, for example, where you have one ventilator tuned up to double the tidal volume, so you can basically ventilate 2 pairs of lungs in multiple patients, came from the ability to take care of gunshot victims in a mass casualty event. We all implemented this in the Las Vegas mass shooting, where they didn't have enough ventilators, but they were able to conduct wide tubing to have 1 ventilator for 2 patients. Now, in a mass shooting, gunshot victims don't have infectious diseases. Now, in a coronavirus COVID-19 outbreak, when you need ventilators, 1 patient may have a larger viral load than another. That is the concern of basically giving up the whole idea of trying to do infection control and keeping patients alive by breathing for them, but sharing each other's viral loads with each other. And God forbid, maybe we have different strains, which there is emerging data there is, and sharing different strains. And we have reports of patients being co-infected with 2 different strains of COVID-19. Whether this increases mortality or not, that is a concern. And while we do appreciate all the creative methods of sharing ventilators or even, different ways of doing personal protective equipment because we don't have enough of it, a lot of it is actually hurting a lot of us healthcare workers. And the concern is actually not only are we able to try to flatten the curve, but will we even be able to have people to treat this curve in 1 or 2 weeks' time?
So, Calvin, how many strains of COVID virus are there right now?
Right now, the hypothetical research that suggests 2, L strain and an S strain. The S strain being mild and more infective because it's more asymptomatic, so people tend to spread it more. People don't avoid them as much because they don't look as sick. And the L strain, which suggests to be deadlier, they kill people faster. And then the hope was, morbid as that word is, hope. Now, the hope was that it was so deadly, the L strain would kill enough people that they wouldn't spread it fast enough. They would be so sick, people would avoid them. But in this scenario, it seems that whether the S strain is actually deadlier than we thought or the L strain is in the United States, but I'm seeing many, and I'm treating and I'm intubating young people in these emergency rooms. I intubated many people with no medical history under the age of 40 or 50. And we know some 20-year-olds also on life support. So it just suggests that there's so much more that needs to be known about COVID-19, and there's different various presentations. And we're just worried that we'll not be able to handle all of that.
Deborah, we're also hearing lots of talk, and a lot of it from the White House, about medications that can be used to treat the virus. There's been talk about some drugs that may be effective against COVID-19. We've heard that from President Trump. I mean, what is the scientific data behind this?
Well, unfortunately, this is a case where enthusiasm has got far ahead of the data. The French study that created such excitement really was a study of 36 people. It was not randomized. It was an open label, non-randomized trial. There were a total of 36 people, 16 controls. Only 1 person in the control group was age 75. In the experimental group that got any treatment at all, there were 20 people who got hydroxychloroquine and the zithromycin. And what happened there was only 6 of them got both drugs together. So 20 people got hydroxychloroquine and 6 got zithromycin with hydroxychloroquine. Those 6 people did better in terms of reduced viral load faster. But do you want to make a policy for the whole country based on that? In fact, there's something rather exciting going on in Shanghai right now, where medical advisors to the government have recommended that in addition to the clinical trials that we desperately need for any treatment for these seriously ill people, looking at drugs like the antivirals, looking at the new experimental ones as well, in addition to those clinical trials, they are using intravenous vitamin C and having really impressive results. And there are growing amounts of data with intravenous vitamin C. If you look at the website for the National Cancer Institute, the PDQ on it talks about successful trials using intravenous vitamin C in the treatment of cancer with chemotherapy drugs, not against them, but in combination with medical treatment. Because as Dr. Sun knows, seriously ill patients need a lot of support. So if you can combine intravenous vitamin C and prednisone and, of course, fluids and all the things that you can do to keep these people alive through this cytokine storm that is created by the virus, then we're seeing more success. And the advantage of intravenous vitamin C is that, unlike hydroxyquinoline, which can be very toxic to the heart, there are no reported serious toxic side effects. Unfortunately, one couple heard about this enthusiasm from the president, went out and got themselves some of this drug and took it, and within a half an hour, the man was dead, and his wife was very seriously ill, because we know that hydroxyquinoline can really, it's both chlorine and quinine. It is very toxic to the heart, particularly of older people. And the idea that we would give that drug to widespread numbers of the elderly when we know it can be toxic to the heart makes no sense as far as many epidemiologists are concerned.
Calvin, we've just got a little bit of time left, but you wrote in a blog that people should not go to an emergency room for testing for COVID-19 unless it's a life-threatening emergency. Explain that to us.
Absolutely. With this whole lockdown in place, I'm still seeing record numbers of young people still coming to the emergency room, co-infecting themselves, bringing them back as vectors and spreading to their family just because they need to be checked. And unfortunately, that doesn't make sense logically in an epidemiology point of view, in the fact that they come to the emergency room to get tested. They have a high chance of getting infected right after that test. That test becomes a false negative. They come to the emergency room, they get swabbed, they may not have had it, and on their way out, they catch it at a door handle or a patient that sits next to them and coughs, or just being in the emergency room and inhaling that viral load. We know that this virus is aerosolizable and lives in the air for 3 hours. And then they go home and they can catch it on the subway or on their way back. It's not like a drive-through test where in the privacy and the cleanliness of your car, when you get swabbed, no one's going to cough on you right afterwards. It increases the accuracy of that test, or a home test kit being sent to you. So by coming to the emergency room just to be checked, you're just increasing your chances of exposure to this virus and bringing it back home with you, not only harming yourself, but other people, thus further bringing more people to the emergency room. And if you get a negative test in the emergency room, you may have caught it on the way out. You may get a phone call 1 or 2 days later, which that's how long it takes to get the test back. And then they say your test is negative. You get excited. You're less likely to self-quarantine. You hug grandma. You give her the virus. And then 1 or 2 weeks later, she's on life support. So, and also going to what Deborah's point, that's true with the treatments too. A lot of people are now coming to the emergency room demanding this treatment. We've run out of azithromycin and we've run out of hydroxychloroquine. And that's unconscionable to me that we are not only hurting these patients with these drugs that are unproven. Hydroxychloroquine can also make you blind if it doesn't kill you. But also we are denying these drugs to critically ill patients, rheumatological patients that depend on these drugs to live. So they are now coming to the emergency room in emergencies because they have run out of access to hydroxychloroquine that they've been dependent on their entire lives. And they get mixed in the crowd with COVID-19 patients, and then they catch it, and it creates this downward spiral. We are circling the drain by creating this mass hysteria that is only hurting us. And if you're exposing more of us to the word well as healthcare workers without the personal protection equipment that we need, we're going to get sick, and we're just only causing this to be a worsening situation that we can't get out of.
Right, and that's where we have to leave it. Thanks very much to both of you for being with us. That's it for this edition of The Heat. I'm Anand Naidu in Washington, D.C. Thanks for watching.